Good morning, everyone. Let's restart. Welcome to day 2 of SNOMED CT in Europe. You now know me and you know Ian. Ian's going to start the morning by chairing a panel of the great and the good. He will introduce who the great are and who the good are, but they're not necessarily the same people. Okay. Can I just remind you that there are people on Zoom watching the proceedings, so if you do ask questions and so wait for a mic and phrase your question so that a Zoom person can imagine what's going on. And let's start the proceedings. So over to you, Ian.
Thank you. Thank you, Doctor. Yes, all right, well, I've less than that. So can I invite the great and the good onto the stage, please? They know who they are. I think we should have audience voting about who's great and who's good, but no, we'll kind of leave that where it is. So I'm going to actually get the panelists to introduce themselves. I'm not going to do it for them this time. So I think we should start with ladies first, really. So.
Thank you. So I'm a lady at least. We'll see if I'm great or good or both. My name is Rossander. I'm a physician. I'm a urologist. I work and live in Sweden. By now, I only work with informatics and mainly SNOMED CT. I don't work at the NRC. I work at one of the regions.
Sylvia?
Hi, I'm Sylvia. I'm from the Netherlands, from the Ministry of Health, and I have a background as a pharmacist and a researcher, and I'm now working on policies on implementing SNOMED, at least.
Tom? We'll work our way down.
Thank you. My name is Tom, the same as yesterday. So I'm the head of the unit called Data and Policy Information from the Federal Public Service Health in Belgium.
Good morning. Still Konstantin Hyppönen like yesterday, indeed, representing the European Commission DG Connect.
And good morning, everybody. Last but not least, I'm Rory Davidson from SNOMED International. I'm the Chief Digital Information Officer.
So votes on who's good and bad? No, we'll leave it where it is. Right, so the panel discussion really is around looking at how SNOMED can best support the development of digital health in Europe, which brings in a number of things that we talked about yesterday, particularly around developments around the EHDS, particularly the increasing number of SNOMED EU member countries that we now have as part of that, but also not forgetting us poor relations, so the ones that are in Europe but not part of the EU. Really focusing on, as we talked about yesterday, around primary care, around secondary use of data, and around really the developments moving forwards. But I want to take a step back. So Charles and I present to a number of groups of clinicians around SNOMED. And we quite often start our presentations by taking a step back and almost ignoring SNOMED in some ways, and look at what's the real requirements for structured data, and why do we need structured data? Why is it important? What about things that are happening in terms of some of the technology advances, so things like NLP and AI that are moving forwards and feed into that kind of equation, if you like. And I'm going to start this panel, eeny, meeny, miny, mo. I'm going to start this panel actually with Anna.
Why is it more important now?
Why is it more important now? Well, why is it important to you as a clinician, I suppose? More to the point, why do you want to do structured data, or do you want to do structured data?
I want to do structured data, but I'm maybe not the standard clinician since I'm here, right? But I think one argument towards many clinicians would be that since knowledge development is so fast now, there's like no way you can be good at your area and keep up with it in a decent way. So you need help with that. So that's where structured data will help you both find like relevant new knowledge, but it would also help you produce new knowledge, right? And I think most clinicians would buy into that. So that's one reason. Like the speed of increase of knowledge has changed over the years. I've heard sometimes like you need to read literature in your medical field for 40 hours per week to keep up. I don't know if it's true. It wouldn't surprise me.
Okay. What about Sylvia? I'm not doing ladies first, I'm just thinking what you
Not
might
all the
ask.
time.
What the question? Not.
Well, the reason I started working at the ministry on structuring data was my research that I did before. And then I manually went through files and files to find relevant data. And that's not something we can continue to do. And now what we're trying to aim for is interoperability. And we have a lot of EHR suppliers, and if we want to get the data across for those healthcare professionals, we need at least some structure to transport that in, the data.
So what about you, Tom? From a national perspective?
From a national perspective, why do we need structured data? Because you can find, as already said by Anna, everything gets quicker now. You have to find quicker the information, and the only way to do it is by structured data. Even on a national level, if you want to do policy, if you want to do make decisions on that, it's very hard even for government to find the necessary information that we need. And by structuring data and by forcing, in a way, everybody to structure data, the hope is there, and I'm saying the hope, that we can find the necessary data where we can find them. European Commission with the European Health Data Space will help there. It will be, I believe, a leverage, a way of moving things faster, a way of moving towards, for example, metadata catalogs, where we can find the structured data more easily, etc. That we know, okay, if we're looking for data, if we want to make a policy, that's where we can find it. That's why, that's the main driver, I think, for a government to go ahead with that.
Okay. So Konstantin, I guess, from a Europe perspective?
So you may recall I was speaking yesterday, and I said one thing. I said that structured data is usually of higher quality. And during the break, one person came to speak to me and said, well, Konstantin, you said it wrong. You are wrong. The data being structured doesn't automatically mean that it's of higher quality. Yes, it has different application possibilities. It has different qualities, if you want to call it that way, but it's not necessarily by itself, due to the fact that it's structured, it's more correct, or it would be automatically higher quality. And I think that's a good point. At the same time, we see benefit in structured data. We know that some use cases are simply impossible to implement without structured data. To give two examples, e-prescription or lab results, these are where we see a lot of structured data happening in any case, and it's impossible to build them using PDFs. And also in structured data, in secondary use, it's really useful because otherwise we sometimes end up in a situation garbage in, garbage out. We want to avoid it, and we see this also, for instance, in the cancer imaging infrastructure we are supporting through financing, and that's to develop new algorithms for AI training and so on, to cure cancer, to build new methods for that. We see that, simply images, they are not sufficient. What we need to supplement those images is quality metadata. Otherwise, AI developers cannot really utilize the images to the best possible extent. But of course, structured data, it has its own limitations. It doesn't, well, sometimes it's a bit more burdensome to enter, and I think it has to be not too burdensome for health professionals to deal with the structured data. Maybe here we could explore the possibilities offered by AI. So maybe we will see in the future more systems supporting health professionals to code data, maybe discover some mistakes in the coding, or maybe create summaries out of data. And by the way, creating summaries, we get messages from some stakeholders saying, look, there is so much data, we are drowned in data. It takes so long to study all these documentation on an incoming patient. So structured data is, of course, much better for that, because you can create summaries from the previous data if the data has been coded and put together in structures. But maybe AI could be useful to further enhance this. And in January, we published a package for SMEs and other developers of AI systems. So hopefully we'll see innovations like that. We'll see also innovations perhaps in Gen AI, supporting the development of clinical decision support systems, which we have already, but maybe AI could implement and improve them in a better way. So a lot of possibilities offered by structured data by itself. It's not necessarily of the high quality simply because it's structured.
So what about the techie on the end? What would you do with structured data?
The token techie on the end. The elf on the shelf, that's me. So I think it's just following on, obviously we need to talk about AI nowadays, and this is kind of the world that we live in. I think we're at a very interesting point, an inflection point in technology and where we go with data. And structured data is really key and important in that. It plays the key part of everything we going forward. I think if we believe a lot of the hype that's going on around about AI, and there is a lot of hype, you speak to some software engineers and they'll very confidently tell you, you don't need structured data because the AI can infer the knowledge, and that's absolutely incorrect. It cannot infer the knowledge, and especially not in healthcare. You can do this when you're doing narrative, when you're doing summaries of content and text. It's a very different world to, we need to be able to deal with a clinical decision, and we need to be able to deal with a patient in the encounter. So we need that structured data to be understood by the AI models to start with. And until we have that, that's kind of the key. And so it raises challenges, and to your point, Konstantin, that structured data is not the be-all and end-all either. It raises its own challenge because we talk about structured data, but the key is structuring it in the right way. It's very easy to structure data in a really, really bad way. So we need to make sure that we use information models, obviously SNOMED CT, but they all play a part in this kind of bigger picture of why we need structured data. Once we have that structured data, then we can really leverage the technologies that are becoming available to us, because they're working on knowledge, they're working on curated information, not just links they've got from what vast searches of data that's available to these models at the moment. So I think we're going to see generative AI, where it is at the moment, is in its very early days. I mean, it feels like it's taking over the world, but it's a long way to go. There's a very, very long way to go before in healthcare becomes useful. Partly because of the lack of structured data in these generative models at the moment, but also the lack of healthcare data that's available to these models to be trained. So imaging is very different. Imaging's been doing there's a lot of AI techniques being used in imaging for years now. This is not a new, undiscovered world. But when we start talking about patient information, data, healthcare data, there's not a lot of data that's available to these models to use. And so until we have some of that access, there's some interesting questions that come out of this about what does this mean for privacy, what does it mean for patient data, access, everything. Very different in different territories and different countries. But until we have access to that data, and that data is structured, then I think all of these AI models are going to be somewhat limited. And so until we get that over some of those levels, and there's a lot of work going on, the AI policies being put in by the EU are extremely forward-thinking and ahead of the game. The US is doing something similar. Other countries are thinking about this as well. But we need these policies in place to understand how do we use the data to train these models. And those models, this data needs to be structured. and bring it back to SNOMED. And this is where SNOMED plays a part alongside the information models that make sure that that data is in the right structure, in a useful structure that can be used by these technologies going forward.
Can I add one tiny detail? If we go back to the question, why is it relevant and why do we need to structure it? I think it's because in the structure, we can have an agreement what it actually means. And with that agreement, you can do all these fantastic things, but without an agreement of the meaning of an information element, it can be everything and nothing, and therefore also quality, I guess.
Okay.
Back to you.
Don't ever follow the script, it's fine. So, okay, we've kind of made the point, I guess. The structured data is a good thing to do. So assuming that we've made the case, if you like, where do we start? So how do you persuade clinicians that it's a good idea? And I know you're not the average clinician, but you know, if we go along to busy hospitals, to busy clinics in primary care, and the clinician is really busy seeing patients, how do you sell this? What's the selling point to a clinician? I'm going to start with Tom this time, because I'm like that.
I thought so. Well, this is a question that I asked yesterday also. I don't have a magic button, and it's like we're discussing about the Holy Grail here. And we're putting again the pressure on the physicians. But if sometimes I'm a practical guy, and if I look at the doctors in the room, hopefully will confirm what I will say, is that if you have a consultant, or if you have a consult and you have to see 4 patients in 1 hour, the pressure is on. How do you engage clinicians then to start thinking, okay, what I do with putting information in an ER chair, how do I go with that? What's the information that I get out of there? But the big question here is not how do we engage clinicians, what's in it for the patient? And I think that's the most important question also, or another important question is, for whom is the doctor gathering the data? Is it for himself, for the records, for financial issues, or is it for the patient at the end? And I think that's the question that we all have to reflect in arguing and discussion with clinics, with physicians, in order to get them to that point that they can see an added value of, okay, let's do it another way. I know I did it many years, copy pasting, discharge letters, etc., to get things going on. But here's another way where I can find the profits and the benefits of it. It's perhaps a possibility, but I don't have any magic button.
I thought you did, but obviously not. Konstantin.
I didn't have any magic, unfortunately, myself either, but maybe starting from a very obvious point that when patients visit hospitals or other healthcare providers and receive care, of course, it has to be documented. That's important for patient safety, for the legal reasons, for legal safety of health professionals, but also for communication to other health professionals, but also to the patient. And I think the quality of communication can improve if the data is well structured. I mean, you could compare it yourself, keeping files on the hard drive. You can have everything just in one folder and disorganized, or you can have nicely structured contents for yourself, even in the future, so that it's easier to find information. And indeed, coming to the point I mentioned already, we hear from the stakeholders, usability of the systems are unfortunately not always at their highest level. And we also see systems which are able to provide useful summaries, like a patient summary of data, which is quite quick to take a look at, to grasp the situation the patient is currently in. and to understand the most important things, and such summaries can be created using structured data, and much more difficult to create using PDFs or unstructured data. So there is some utility to structured data for improving the communication towards patients, to other healthcare professionals, to the peers. Yeah. So structured data has its utility for that, but of course it takes also some input from everyone. So if health professional, if they want to see nice summaries, they also need to input the data in the way that facilitates the creation of such summaries, facilitates this better communication. And I think that's a point of community we could try to use to explain to health professionals that it's not for, policymakers only who want to have the structured data, but it's actually for your peers, it's for the patients, it's for improving the communication quality all over.
Sylvia will go next.
Thank you. Well, I was thinking about how do we engage clinicians, and I'm also working on another kind of different, well, kind of the same on structuring data on another program, and it took it very easily. When are they available? Not during the office times. No, because they're seeing the patients. So they decided, let's make the program where we engage with the CMEOs and CNOs, let's do it in the evening hours when they are available, so they can put in their input. But it's still a small group, and I'm also still looking for the big answer and the magic bullet, but not only saying, oh, we don't know, but we just want to engage with people is, I think, let's look at the other way around. When are they available? What can we offer? Yeah, and I think the selling point of looking at what's in it for them, we can look at money, but I think the patient perspective and improving healthcare quality is more of an internal motivation on why you actually started to be in medicine or in healthcare. I think that's the one to go for.
So Anne, what about you? How do you persuade yourself and your colleagues?
I think the structured overviews are very good arguments. We have a few of those in Sweden, and they are obviously based on double documentation, that somebody enters the data in a secondary system. But they're very fancy, and the clinicians use them like the functionality. So selling to them that you could have this auto-populated from your primary documentation, that would be good. I also think most clinicians, we've talked about it, but we haven't mentioned like primary and secondary use, but that is an argument that it's both for the use at the moment with the patient, but it's also for like follow-up or research or quality control. And most clinicians do both, right? So I think that's the selling point as well. But it comes down to the user interface. And in many situations where I've been, we get stuck with the vendors because they don't do this. It's hard-coded, we can't do it. And maybe this is where we as a community could help out and put pressure on the vendors or help them and show, like, this is what we're after. This is an overview module. This is what we want to show our clinicians. Can you do this for us?
So Rory, can technology help or hinder us?
Well, that's a very handy comment at the end, because that was leading to where I was going to. So I'm going to be kind of a little bit heresy here. So health IT is not very good. Basically, and there's a reason for that, and I don't mean that in a derogatory way, is that health IT does not move quickly. When a system gets put into a hospital, it's a long, painful, expensive process. So a hospital does not want to upgrade every 2 years, or even every year, or even every 5 years. And generally, these systems have a 10-year life cycle, if not longer. And so the impetus to change and to put things in like structured data, which is a fundamental re-architecture of a system, it's a massive piece of work. So we don't have the market that moves quickly as we do in other industries. So my heresy point is, it's not about selling to the clinicians. The clinicians shouldn't need to know they're using structured data. They should need to know that they're using functionality that's going to help them look after the patient, get better outcomes for the patient, and better healthcare systems, more efficiency in their processes. The fact it's using structured data, as all of us in this very kind of specialized world know, that most clinicians don't need to know this. It's about the systems they're using. And so our touch point is with the vendors. And some vendors are very are very reactive and very responsive, because they can be. You know, like I'm sure many of you have dealt with startups who've got some really cool stuff going on at the moment. There's some amazing software out there, but they can't get into the healthcare market because it's a really hard market to get into. You can't rock up to a hospital, to a CIO and say, oh, do you like my new little shiny new iPad AI tool? They go, no, I've got Cerner. So, or any other large system that are there and are very good for the purpose they do. So I think there's a long way to get to, but I think the engaging point is actually working with the vendors and getting the vendors to really start to push this through. Because once they push it through, the clinicians don't need to know they're using structured data, because they'll see the benefit from the functionality, the benefit of the data. So it's making sure we get the systems correct. I mean, everybody's saying that the user interfaces are poor. I mean, everybody's got a story of a drop down somewhere with 1,000 things. And, you know, we used to, in the SNOMED world, that used to be, well, SNOMED's too big. Well, no, SNOMED's not too big, it is big, but the drop down's too big. So there's different issues. We have to interact with those vendors in the right way and make them understand why structured data is beneficial for them, not just for us, not just for the clinicians, but for them and for patients. That's my heretic point over. Well, I don't know, the next question might be more heresy afterwards.
So with heretics, we burn you at the stake outside as well.
There's history.
So I suppose moving this on a bit, so in the context of the primary use of clinical data, to support direct patient care, if we're optimizing data collection, we're all here, we're all talking about SNOMED CT. So why is a standard terminology like SNOMED important? And I guess as this conference is called SNOMED in Europe, then what benefits really would the EU-wide use of SNOMED bring to Europe? So I'm going to start with Konstantin, because that's kind of focused at you, and then the other ones can help you out.
Thank you very much. I think harmonization of data structures, it's a useful tool. We are probably not going to see the full harmonization in any case, simply because there are so many differences in healthcare systems of different member states, and member states are responsible for organizing their healthcare and social care systems and so on. But what we also see that certain level of harmonization is really useful to help decrease the market barriers for different EHR system manufacturers, because if every time they go to a new member state and they see completely different types of data structurization and so on, that's a little bit difficult. So if we are unable probably to get to the full harmonization, but a certain level of harmonization would be really useful for helping EHR system manufacturers build systems with better interfaces and to get them across multiple markets across the whole European Union in the vein of the single market approach. I mentioned already that it's useful to have structured data because it brings some additional benefits. So one of the benefits is translation. And we see already currently SNOMED CT is being used in the My Health at the EU infrastructure, where 12 member states at the moment, they exchange patient summaries and e-prescriptions, and this data is translated to the language of the receiving health professional, which is really useful in case you have somebody from abroad coming to your desk and trying to understand what is happening. So if you get your data, that data in your own language, that's really, really useful. It's a bit difficult to say what will be the next steps. So of course, the My Health at the EU will be growing and so on, but SNOMED CT is one of the terminologies. It's not the only terminology, and in the next months and years, the European format will be defined. And we will see what is the level of, what is required and what is optional and what is preferred, what is recommended in the format. That discussion is currently ongoing, and SNOMED CT is one of the terminologies which is being discussed as part of that work. Also because we need to have the format implemented not only in EHR systems, but also in My Health at the EU for data exchange. And yes, we know that most likely not all data can be translated, that is going to be partial translation of data in those clinical contexts. And yes, we'll still see PDFs floating around, so not all the data is going to be structured because it takes really, really long time, especially if you want to do structured data in a harmonized way across multiple member states. That could take some time. So we'll see slowly increasing harmonization, and we'll see still unstructured data complementing structured data, which we already have currently in My Health at the EU. But given the fact that structured data has its own benefits and terminologies, they have their own benefits, I think we will see their use increasing with the introduction of the European health data space.
Okay, Sylvia, I'm going to pick on you.
Yeah, we can look at the question of why should we? We can also look at it, why should we not? And I think there's not a good answer to explain why we should not do this, because I think it has a lot of advantages. What you already said is to the vendors, if they can work in the same way, but also if you have the same standard terminology, that means that if there's research based on this terminology, we can implement it across Europe. We can share the knowledge across the countries better. So I think that is a big advantage. So I think there's no reason not to do it if we can be more efficient and improve our healthcare.
Okay, Tom.
Well, by preparing this panel, I stumbled across a document of 2014, Starter Guide of SNOMED CT, in Dutch, translated in English also. And there were some benefits put forward in that document on the 4th page, if you want to look it up. It's still the same. 2014 and 10 years later, it's still, like they call in Dutch, and like we've seen all in the community, eenheid van taal, one language, which makes it more easier to get interoperability, to get the quality of care better, more quality of care, let's put it that way. And I think you should all go back to that document and read it once to go through it and say, okay, these are the benefits in 2014, does it still count? And it does. It's still valid, it's still there, and I think that's one of the most important things. To get that interoperability, to get that quality of care higher than it is. I shouldn't read the rest of the document because SNOMED has been updated and has been, but the benefits are still there and they're still valid. So it's something that we should be aware of, and it's still something that it's one of the most important things, I think.
So read it. I was one of the team that wrote it.
I didn't know, it was not mentioned, it's just mentioned the old name that we don't mention anymore, but it's the old name.
That's fine, I remember it well.
I think from a clinician point of view, we often talk about, and I see in these like user examples, there's this example of a person going skiing in the Alps and they break their leg and you don't have the medical, you recognize this. And I've sometimes heard clinicians talk about this and they say, well, those patients are healthy often if they go skiing. They know their medical history. They're not the ones who need this. The ones who need this is like the old lady who lives alone on the countryside and her primary contacts are within a small geographical area. It's the hospital perhaps, it's the GP, it's like the home care staff, it's the pharmacy. And then they would say, so they don't need this. Yes, they do, because if we do this for the skier, it will also work for the old patient or, whoever. So I think this is an argument that you can run into, that it's not needed for normal, common patients, majority of patients are sick and have multiple diseases, but you can also turn it around and say, yes, it does. If we do it for the skiers, it will benefit everyone. So I think that's the point to lift.
Okay. Rory, right, so your continuing employment rests on the answer to this question.
Again. I think it's, remember also, I'm wearing the SNOMED socks, I'm literally, I'm bought into the game. But I think we're here about SNOMED, and one of the reasons why SNOMED is an extremely useful part of this piece. SNOMED was designed from the start to be multilingual. It would be multilingual, unambiguous. We know what we're talking about. That code means the same thing wherever you are in the world. It's always going to be the same thing. So from a point of view of sharing data and interoperability, it's a key part of this. And so this is why it's very important to use terminologies like SNOMED and other standards. And then the reason why we talk about SNOMED, one, because we're here, but also because it is multilingual. It's translated into more languages on a monthly basis at the moment, and that's picking up, and as an organization, we're seeing how we can help improve those translations and grow that translations across the globe. So we're doing what we can to do that. But I think it's back to a little bit following on from your story, Anna, about, it's about the walking wounded or the skier or the old lady, whatever. It's also about the sharing of data for research. Understanding that when something's happened in France or Belgium, and then it's being researched in Poland, we're looking at the same data. We don't care about the language because it's not a language. It's a machine-readable set of content and data that we can do research and analysis on. And that's really key for the improvement of healthcare, for the betterment of mankind. It's very nice, I like saying that. But it means this is how we can do it. This is why we're here, because we know that data being structured using terminologies like SNOMED CT, where there is no ambiguity, and language is not actually part of it, means that we can actually use these new technologies to kind of make massive improvements that we are starting to see around the world.
So the good news is you're still employed.
Excellent.
So one of the things which came out of the discussions yesterday, and also will continue to be a theme in some ways, different countries have different starting points, have different drivers. So it's important to acknowledge that everybody doesn't start from the same place. One of the things which we get asked as SNOMED International is, if I'm implementing SNOMED, where do I start? And the answer is, there isn't an answer. There's different approaches, there are different roadmaps. So what can we do to help, I guess? And I'm gonna start with Tom on this one, actually. I'm gonna pick on you.
If you have seen the presentations yesterday about the implementation, we all, as you said correctly, Ian, we all have different starting points. And it's very hard to say, okay, where do we start? I think that each country has to develop for its own a roadmap, if you may put it, a strategic vision or whatever, and then look at it and say, okay, where can we start? Where will we start? Where do we have the funding for to start? It's also a big important question. And where can we seek help? Where can we get the solidarity of the community to see, okay, where can we help each other to advance more, to advance quicker? And I think that's something also that you have to look at as a country, as a national approach to implementing SNOMED. Learn from each other, learn from the mistakes. The most important lesson and the best lesson to learn, okay, that you don't make the same mistakes as other countries have. And I think that tooling technologies can help you with that, but it's not the most important thing. It's really get that solidarity going on, talk to each other, and learn from each other in order to advance quicker, in order to adapt your roadmap at a certain point, etc. So I think that's the most important thing.
Sylvia, I think.
Yeah, as also presented yesterday, we were, well, lucky is a big word, but we asked Nictus for an advice. How are we gonna start doing this? And we didn't ask SNOMED, but they were very specific in just started some sectors and some elements, very, very focused. But even though we have this focus, we have all those different sectors with different problems, and they're also working with several other standardization organizations. And a thing I know SNOMED does, and really think I will help, is the connection between those organizations so that the different standards also work together. So that even though they implement SNOMED, they can still also use their other standards or their other technologies to their benefits.
Okay, Konstantin.
I think we have started already, or maybe the environment has started kind of on behalf of us, because what we see is overall digitalization of the society. We see that our society is more and more dependent on digital capabilities, on data, and that we see also in healthcare. So more and more healthcare data is processed electronically, not on paper anymore. But of course, there are differences between member states. It might be not always as straightforward as to say that some member states are advanced, so for them it's so much easier to start using terminology such as SNOMED CT, and some other member states are less advanced, so it's so difficult for them because the first type of member states, they have a lot of legacy. And then, of course, it takes much more effort to introduce something new in those legacy systems, whereas for the second group of member states, maybe in the greenfield environment, it's so much easier to start using something really progressive and new. But looking at differences, I think we should not only comparing like who is processing more data and so on, but quite often we say we should put the patients in the center, and maybe that could be one indicator to look at if the healthcare system is being digitalized, whether patients are taking their part, whether they can see their data. We are measuring this specific indicator in the context of the digital decade goals. There is a goal for 100% of people to have access to their electronic health data by 2030. And there we see differences between member states. We see that some member states are already approaching 100 and some others are still below 50%. So there, we hope to see that it will be fully aligned to the 100% target, first of all, in line with the objectives of EHDS. And for that, of course, member states are making use of funding. So there are multiple financial instruments such as the EU for Health and Digital Europe program, but also Recovery and Resilience Facility. Based on the outcomes of the COVID-19 pandemic, many member states have noticed that, yes, digitalization in healthcare is helping them to prepare also for the upcoming pandemics and deal with such situations. So a lot of money has been earmarked for the development of digital health in RRF by many member states. So we really hope that all this support, including financial support, will slowly help member states drive their digital health capacity in alignment with the general trends, of digitalization of our society. So member states are using grants for setting up health data access bodies, for improving semantic interoperability, for starting to use SNOMED CT. There is a lot of support on the offer, and that support is luckily being used by member states to improve in this sector.
Tom.
Perhaps to add one thing to your comments, Konstantin, is when you were talking about it, I was thinking is that it's good that the European Commission is supporting member states, but when you have a patient-centered approach, you should also help the patient. So the maturity level of using the digital data by patient itself, health literacy, or how you can call it, it's also a really important thing. As a member state, you can offer as many tools as you want, as many possibilities as you want, but if the patient, we're talking about health data, isn't using it, then we shouldn't, then there's no use in it.
Maybe I could quickly respond to this important point. I find it really, really important. Yes, there is support also for improving training of health professionals and other types of population. But I mentioned, for instance, the indicator of patients' access to their data. There is also the accessibility angle, and there is also the angle of considering support for more vulnerable groups of people. So for instance, there is a question whether people can authorize somebody else to access their data. And that's really useful for the situations such as with the small children, of course, but also with the elderly population. So if somebody can maybe not use the computer in the best possible way, but they have somebody to help them, maybe there is their daughter or a son who could help, then this person could receive an authorization and maybe help that elderly person to go through this digital society a bit easier. So really important point. Thank you, Tom.
Well, I'm thinking about this access thing, and we're talking about this goal of 100% access, but 100% access is not 100% structured, right? In Sweden, I'd say 100% of people living there can access most of their patient data as free text. Is that where we're going? I think we need to also say that how is it to be structured? And this seems to be like an itchy topic. And since Sweden digitalized early, we are using lots of different code systems and not SNOMED CT. So if you just say it should be accessible, that's not helpful. I think in Sweden, we would need some sort of pressure saying, this is to be SNOMED. Unless we have that, we end up where, I think Stephanie talked about it yesterday, that we need to have a strong argument to the vendors to say, you really have to change your systems. And we need like a national or even European decision saying, this is what we're going to.
Rory, I'm going to pick on you at the end.
Always at the end. I think just echoing a little bit what Tom was saying as well, and talk myself out of a job. So at the moment, technology and tools are there to serve us until our AI robot overlords take over. Until then, tools will do what we want. Technology will do what we want it to do. It's not the blocker. It's just a thing we use to get to the endpoint. And just make sure we understand what that endpoint is. And I think everything everybody said, healthcare is such a complex environment. There are so many players and so many people involved, and the patient's the focal point. But unless we get everybody else lined up, then it doesn't work out. And we've seen that. And there's lots of experiences around the world where we've seen that work or not work. But I think the thing is, the key is how do we address differences, but how do we address the similarities in the approaches? And that's where these types of meetings and these types of forums that we've had through the same international groups and so on, and other groups, are extremely useful to share the knowledge, because there's a lot of similarities. Now, everybody likes to think we're all unique, but it's never quite unique. Stop talking now. Exactly, technology's not the problem. They are taking over now. That's why he said the secret. But so I think it's about learning our similarities and doing this. Because there's a lot of similarities actually across all the countries, even irrelevant of languages. We all have the same issues. We all have similar healthcare issues to deal with. We all have aging populations. We have pandemics. All this stuff, we all deal with it together. And so the more that we do this together as a community, more successful. And it's not going to be tooling or technology or AI that's going to improve that. It's about how we all work together that's going to make the difference. And I think it's to Anna's point about it's very easy to say, yes, we've got access, but I think we've got to give rules and regulations. And I know it's never a popular thing when it comes down from the top of the tree. But sometimes you need that tree to be at the top, because you need to be able to say, yes, all right, you've got 200 code systems, but that helps nobody apart from you and your own local code systems. So you need to use 1 or 2 or 3 or whatever the decision is, but you need a strategic national approach to standards, or we end up with essentially mayhem, and there aren't any standards, because they're not standards at that point, they're just another system. So I think it's having that structure and having that decision as far up the tree as possible, I think, and buy-in as far up the tree as possible is kind of important. And I know everybody here has had to deal with different levels of government and levels of agencies, and some are easier than others. But unless we have buy-in from that level down, then we're swimming against the tide. So I think it's making sure we've got the sales pitches, we understand why we're doing this, what's the point of everything we're talking about. Then it's a much easier discussion, because when everybody's on board, everybody's working together. So, I mean, it's a bit utopic, but hopefully that's where we'll get to one day. So.
And just remember, the great thing about standards is there are so many. Right, I'm going to open this up to the audience because that's kind of like a good end point. So do we have questions from the audience? Pim, so Alison.
Yeah, thank you. I'm a strong believer in structured and encoded data. It's two of them, but I don't believe a physician or a nurse is capable of doing all the things we want to do. We want them to do. So I think then I'm looking at Rory. So how can technique help? I know if somebody saw the demos from Nuance and Microsoft Docs, that's the future. That's free text to structured and code. But how can SNOMED and how can the National Release Centers help to accelerate this process of getting the future nearer? You did a great challenge.
Well, I think so. You're absolutely right. I mean, there are technology advances. I mean, there's a great sales pitch. I don't know how brochure-aware or not it is, and I think it's one of the larger vendors where they've got the doctor standing there dealing with a child in a patient encounter and just speaking out, and it's heard and dictated and automatically gets coded. And whilst I'm sure it's not quite as smooth as that nowadays, it will be. And we will be going there, and whether those interactions are just voice or whether it's still typing or whatever it may be, I think we've got to find ways to I think it's how do we open up the marketplace to these newer vendors that don't always get access to it? And that's a bigger challenge in healthcare generally. It's a very hard, as I said earlier on, it's a very hard market to get into. It's very hard for new software vendors to get involved in healthcare. How do we help them? How do we make sure that there's a wider market that's not just a small kind of monopoly we get in some places? And demonstrate what can be done. And this comes back to the clinician's point, and because the clinicians ultimately are users in these systems. If the users want these things, then they'll end up being in the systems. And so how do we demonstrate what can be done? Whilst not making sure that we get blinded by the cool tools, because there's a lot of that. So how do we improve this? There's so many ways. This is why it's a bit of a rambling answer, because I think there's lots of ways we can do this. And SNOMED's we've got lots of information about how we can do some of these things. There's some great data analytics documentation. There's lots of stuff in implementation. And I think it's how do we get that knowledge to the people who need to have it about what's available to them?
Can I ask you a question?
Okay.
What about like Smart on Fire? Could we try to support that? Could that be a way to...
Smart on Fire could absolutely help, yeah. I mean, it's one of the programs that could help move this forward.
So what's happening?
I don't know. I'm in SNOMED.
Exactly.
Exactly.
So can SNOMED International work with either them or somebody similar?
No, so we do work with Fire on HL7, well, HL7 primarily, not Fire, obviously. So we work with these groups, but some of these programs we are part of, we're not basically driving or managing these.
Could you?
We could do, yeah. Shelley,
help!
So I mean, so again, I think one of the pictures always worth talking. Obviously, we're here talking about SNOMED, but SNOMED is just one little piece of that puzzle, and it's a very important piece. But you need the rest of those pieces. So whether it be the information models, whether it be the Fire access points, whether it be the front ends and the UIs and the rest of the tools. And so there's a lot of pieces that go into this puzzle. And so what we do in the organization is we do our best to collaborate and reach out to all those that we can, and all those that are willing as well. And let's be very clear, not everybody's willing to play. And so we want to play with everybody because it's kind of fun, but also we want to make this stuff go forward, and we know that we cannot do it on our own. SNOMED is just, it's very good terminology, it's foundational reference terminology, but on its own, it's just a set of text files. It needs to have everything else around it. And so there's a lot of, the implementation team, Anna's here, going to talk some great stuff later, but we do a lot of documentation about how can we do this, and we keep on doing research on how we can improve that going forward. But the technologies are moving, to Brim's point, the technologies are moving so quickly. I mean, we talk about AI now, but we're not talking about VR yet, or AR, but we will be talking about that very soon. And that will be another way of actually doing patient. It'll be image recognition about what's happening, and the AI tools being able to narrate and pulling a summary about what's actually happened in that patient encounter without any words being said. mean, God help us. But it will be there one day, and it's not maybe tomorrow or next year, but that's the direction to travel. We're in a really exciting time and a dangerous time, and it's about making sure that we don't make jump decisions because it's cool and sexy, but how do we make sure it's the right decisions? So.
Konstantin?
Maybe just to share excitement about the future AI systems, so full support to that, and hopefully indeed the systems will improve significantly using AI, but in many cases what we see is also that much simpler systems could be used even for coding. So sometimes when we look at, oh, the structured document has 200 fields, what a horror. How the health professional is going to fill that in, and the reality is that there is no need to fill in all 200 fields, because most of them, they are generated automatically because of the context, because of the previous situation. So yes, there is a burden to some extent, but good systems are able to help to alleviate that burden.
Where are we going?
So I was planning on going in a slightly different direction, so if there is anything related to...
It's entirely up to you.
Okay, yeah, good. We've been talking about joining forces, and this is Europe, and like, depending on how you count, it could be like 20, 30 something countries. So how do we do that practically? And I could think like there are NRCs, there's commission, there are clinicians, and like maybe getting the vendors in or something. So I would like to hear your perspective on how we practically join forces in creating this common good. Thank you.
Who wants to take that one? Oh, that's what I like, Sylvia. Brave.
Well, one word we didn't mention yet is it's not a word, it's multiple, it's the EHDS as a starting point. Because we have this very nice regulation coming up where we have certain data we want to share. So start there, make agreements there. Make sure they're actually implementing all that said, so it's not a multitude of everything. But we can work together on those, and if that's done, let's continue. But maybe Konstantin wants to add something to that as well.
Not much to add. Thank you very much, Sylvia. So indeed, the HDS is not merely a regulation, but it's also an environment for all of us to feed in and collaborate within. Hopefully, we will benefit from that support, from the environmental support provided by the regulation. But of course, it would require a lot of input from different professions, different groups of people, health professionals, IT technicians, and policy decision makers, and also semantic community working on, for example, formalizing the European format and establishing all the necessary elements for making the EHDS happen.
Okay. I'm just looking at the time, so in the interest, I'm not going to take any more questions, but I think we should think about starting an online discussion around these issues, apparently, judging by the questions. The one thing, there's one point online which is not necessarily a question, but I do think it's an interesting point, and I know the person's made it. You mentioned pushing the vendors to implement SNOMED and interoperability features in their products, which is great. But you also need to push the system's customers to purchase those products and features. Otherwise, the features just will stay unavailable, essentially. So you need to act on the entire ecosystem and not just on the part of the actors within it. Interesting thought. So I'm going to finish there. So I'm going to be good and keep to time, which is unusual for me, I know. So I'd like to thank the panel, and I'd like you to thank the panel.